Alrighty, good afternoon, everyone. We're going to get started now. I'm Kayla Nagawa, and I work here at the UCI Cancer Center, so it's with my great privilege to introduce Dr. Mehta. But before then, I will be helping to facilitate this breakout session on hormone receptor positive breast cancer, so hoping to make sure that you guys hear at the right breakout. We will have a presentation followed by questions and answers as time allows. Use your index cards that are inside your folder to write down your questions. If you don't have any, I have more to give to you. We'll collect the questions at the end of the presentation and share them with our presenter. So please be mindful of your questions and make them broad enough to benefit the whole audience. At the end of the session, you will have time to network and share experiences with other participants. And after this session, lunch will be served here in the main room, and you will have about an hour and 15 minutes to eat and enjoy the expo area, take photos at the photo booth, network, and rest. So we will reconvene at 1:15 here in this ballroom for a guided exercise activity. So without further ado, I'm so happy to introduce Catherine, who share a little bit about her story, and then be introducing Dr. Mehta. So if we can give a round of applause to Catherine.
Good morning. I'm really excited to be here, but the first thing I want to do is share my shirt with you because you guys will all get it, because some people don't get it, so. Everyone on the outside, next is just a baseball team. All right. I just want to share something quickly that 2019 is my year because in 2019 I'm turning 60, and when I was diagnosed metastatic, I thought I would never be old. Sorry, but 60 to me is like getting, past middle age and getting to be old, so I'm really excited about getting old. And 2019 is my 15-year anniversary of living with metastatic breast cancer. So I got some fun things planned. So I was diagnosed in 2003 with stage 3 breast cancer, did everything I should, just like Dr. Lawson was talking about. And about 9 months post-treatment, I was on tamoxifen. I was diagnosed stage 4 metastatic with mets to my bones. It was the most devastating thing that has ever happened to me in my life. I thought that I only had a few years to live, and if I was, whatever amount of time I was going to be living, that there would be no joy in my life. And how could you have this life with no joy? So that was actually the hardest part for me, was that thinking that how could you have joy in your life if you have this terminal diagnosis? Obviously that's not true, but at the time I thought it was true. And so that's kind of my project, is I want to let women who are recently diagnosed, however you're feeling is perfectly normal, and you won't always feel like this. I've gotten to the point that I really don't think about cancer very often, and when I do think about my cancer, it doesn't cause me anxiety, it doesn't cause depression, it doesn't cause worrying. It's just something that I have. And I think that comes from just the time living with the disease and knowing that there's a lot of treatments, and a lot of treatments have worked for me. And I've had some help in changing my thinking about cancer through like mindfulness training and therapy, and a lot of things have helped me. So I've come to this point that I feel almost harmonious with my cancer. We are living harmoniously. Just don't do anything out of the ordinary, and then I'm okay. And that's the best way for me to live. I don't want to live in a state of constantly in the fighting mode of fighting my cancer, because that's not good for me. So I've come to this point where I'm living this awesome life, and when I go to the doctor, I focus on my cancer, and that's about the only time I focus on my cancer. So I'm happy to be here, and I'm hoping that you all can get to the 15-year mark also, and maybe I can follow Sandy and get to the 20-year mark. Like, she's the person I look towards, and then I'm the person maybe a 10-year looks towards. So I'm really happy to be here, and I'm going to do my introduction now for the doctor. It's my honor to present Dr. Rita S. Mehta, oncologist at UCI Chow Family Comprehensive Cancer Center. Dr. Mehta dedicates her time and energy finding a cure for breast cancer. She continues to educate students as a professor at UC Irvine in the Department of Medicine. She's working on several clinical trials and has pioneered procedures aimed at reducing the size of tumors before they are surgically removed. Let's give Dr. Mehta a great welcome.
Thank you for that nice introduction. I'm not so used to talking to patients in a big gathering like this. They usually come to my office, it's one-to-one, or sometimes with family members. So if there's anything that you don't understand, please make sure that you raise your hand so I can explain it a little better. Because I think you're all at a different point in your journey, and I know that breast cancer patients learned so much about breast cancer that it's when a patient is sitting in front of me, I learn as much as what the patients are learning from me. So we are exchanging ideas because patients have been on Google, they have looked up things, they are very well educated because we have such a good breast cancer advocacy that patients will ask, doctor, why don't you do this? Doctor, why don't you do this? Why, so those are very good questions that you have to keep challenging us because ultimately our job is to take care of you, and ultimately our job is to make you live longer as much as possible with as good a quality of life as much as possible. And my hope one day is all of us will die at the same time at maybe 100, but not from breast cancer. But that's a way off right now. But one day, hopefully, that should be the case. So I do have some conflict of interest. My institution received grant from AstraZeneca for a clinical trial that I ran at the institution. And I also received a grant for SWOG S0226, which is run through Southwest Oncology Group Research Network. And this was a study of S0226 for hormone receptor positive breast cancer, and it was a 700-patient study. It's my baby, and I'll talk about it probably the most from all the clinical trials that I'll be talking about. So SWOG S0226, what does it show? Does fulvestrant added to anastrozole improve overall survival compared to anastrozole alone? So does fulvestrant added to anastrozole improve overall survival compared to anastrozole alone in first-line treatment of hormone receptor positive breast cancer? Does ribociclib added to fulvestrant improve overall survival in first and second-line treatment of advanced breast cancer? I think you must have all heard about TAILOR-X study. Does chemotherapy added to hormonal modulation improve distant disease-free survival in treatment of early breast cancer? SOFT and TEX trial is questioning whether addition of ovarian function suppression and exemestane or tamoxifen, these are drugs, one drug takes away the estrogen and the other one blocks the estrogen. Improve distant disease-free survival, meaning improve the odds of getting metastatic breast cancer, reduce the odds of getting a metastatic breast cancer compared to tamoxifen alone in premenopausal women as adjuvant treatment of early breast cancer, in chemotherapy naive or post-chemotherapy subsets. Chemotherapy naive, these patients never had received chemotherapy, or patients who received chemotherapy. So those are two different subsets. And Astra's study was another study which again asked the question, does ovarian suppression, function suppression added to tamoxifen improve survival in young premenopausal women post-chemotherapy? So let's talk about what is an endocrine sensitive disease, that is patients who can still respond to endocrine manipulation. So let's just take an index case. Usually patients will present with, some patients will present with back pain. They would be somewhere in their mid-50s. So the first time, they sometimes may go to an orthopedic, and they find that there's a pathological fracture in the spine area. So then you start looking to see why there is a pathological fracture, which isn't supposed to be. And you find that you do a biopsy of that area, and you find that this person has a newly diagnosed metastatic breast cancer, meaning that they were never diagnosed with breast cancer in the past. They underwent mammograms. Mammograms did not show anything, routine mammogram. And the first time somebody gets diagnosed with metastatic disease is when their cancer is in the bone. That means it's already spread. So let's say this patient has bone metastases, liver metastases, metastases in the omentum. So this patient was started on fulvestrant and anastrozole, and she progressed after 3.5 years. Then she was started on palbociclib and fulvestrant. And there was a trial called Trend trial, which suggested that if you continue the same agent and add CDK4/6 inhibitor like palbociclib, that these patients can live longer. And so far, she remains progression-free more than 10 years later, 2 years later. Then let's talk about the second case. A postmenopausal woman presents with shortness of breath. Again, she does have history of early breast cancer several years ago, 10 years ago, and was diagnosed with hormone receptor positive, HER2 negative breast cancer. She received chemotherapy, radiation, and 5 years of endocrine therapy. She did everything possible, and she was off 5 years of any treatment. And then 5 years later, the scans show that she has metastases in lungs and bone. So now we call that development of visceral metastases. Visceral metastases is when the cancer is in the lung, liver, and brain. Bone-only or soft tissue disease is generally, it can be small volume bone disease, it can be large volume bone disease, or it could be in soft tissue, it could be in the skin, it could be in the chest wall. So this is the patient who started on anastrozole fulvestrant based on SO226 trial that I told you about. And now it is one of the American Society of Clinical Oncology that I had privilege of deciding whether somebody should be on this treatment or not. And it seems that it is one of the treatment options for patients to go on anastrozole fulvestrant based on a ASCO 2016 guideline. Now, she progressed at 3 years, and now she has been offered palbociclib and letrozole, and she's disease-free for another year. So I'm keeping my fingers crossed. So how many trials do we have in endocrine-sensitive disease? That means patients who were being treated in first-line setting, or patients who have been away from endocrine therapy at least 12 months. That's generally the definition of endocrine-sensitive disease. That means tumor doesn't remember, at least that it was treated 12 months ago with an endocrine treatment. So it has to be at least a 12-month disease-free interval and treatment-free interval before a patient progresses. That means it's possible that we can use same or similar agents to get to the cancer again. So we have a trial called Paloma-1 that was run by our UCLA colleagues, and that showed that median survival of these patients is about 37 months in the experimental arm as opposed to 34 months in the control arm. So remember, the median is just the 50% mark, right? There are some patients who don't make it to 50th mark, and there are patients who make it for several years, as like some of you are here who have made it to several years. So that's very important to do large trials instead of us just talking about anecdotal cases. Anecdotal cases give us a certain sense, but ultimately our treatments are based on large trials. So Paloma 1 was that trial. So on an average, it seemed to suggest that there was a 10% benefit on a relative scale of patients who went on combination arm. So based on that, Paloma 2 was launched to see if we can actually improve survival. And it's a larger trial. So Paloma 1 was about 200 patients trial. Paloma 2 is about 600 patient trial. Then we have a Falcon trial, which is looking to see if we should use fulvestrant against anastrozole alone in endocrine-sensitive disease, and whether we can improve survival. At early data follow-up, it suggests that it may be a 12% benefit, though it is not statistically significant yet. Remember, large numbers give us statistical confidence. Small numbers cannot give us statistical confidence. That means it's possible things could have happened by chance. So we want to make sure that we have enough patients, if our trials are powered to show that patients have a good chance of not just being in a random sample size, but statistically speaking, we can be confident that this is true benefit of medication we added to patients' armamentarium. So the other study is Mona Lisa 2, which is aromatase inhibitor plus ribociclib versus aromatase inhibitor alone. You probably have heard of anastrozole. And again, we don't have overall survival data yet. It is not reported. The median on the control arm was 33 months, but it is very early. It's possible that this trial may show about 25% improvement in overall survival. Again, I'm talking of relative benefit in terms of improvement in survival. So we have another trial, Mona Lisa 7, similar trial, similar patient population, except in premenopausal women. We have Monarch 3, which is another drug called abemaciclib, and which has a slightly different set of side effects than we have with patients who receive palbociclib or ribociclib. So again, survival is not reported yet, but all of these agents, palbociclib, ribociclib, abemaciclib, they are part of agents which attack CDK4/6. They are CDK4/6 inhibitors. That means they try to stop the cell cycle progression. And that is tumor cell cycle progression. So these agents have consistently shown that they can control the disease at least by 50% or around 50%, of 40 to 50% improvement in progression-free survival in different trials. So that's a big benefit for patients because then they can do what they want to do. They can go out, they can celebrate life. So that's very important for them, but there are side effects. So what they do is they also, in these trials, they also build in quality of life data. So to see if that patients can live longer, but with good quality of life. So we do have side effects. We have side effects of fatigue, we have side effects of mouth sores, we have side effects of some minimum hair loss. Some patients have diarrhea from abemaciclib. So far, what we know is despite all these challenges that the patients face, if the tumor is under control, they seem to have better quality longer if their tumor is controlled for a longer period of time. So while we wait for overall survival data from these studies, which reach statistical significance, we can at least be sure that they control the disease for a period of time. So again, these are the same set of trials that are important in assessing if patients are going to benefit from our new treatments. And this is the trial that I had the privilege of leading, which is S0226. And here patients were divided into two groups, patients who had never been treated with tamoxifen in the past and patients who were treated with tamoxifen in the past. So if you look at the experimental arm, the overall median survival was 15 months. For patients who were on the control arm, the overall survival was 42 months. This is the overall population. Now, if you look at patients who have never been treated with tamoxifen, that means the tumor hasn't learned the trick of the trade. Those patients, the median survival was 52 months in the experimental arm and 40 months in the control arm, with a hazard ratio of 0.73. That is relative benefit. So what is the relative benefit of the combination? It's a 27% relative benefit. And how do you say what's the amount of benefit? The median benefit is about 12 months. So 40 months versus 52 months, so the median benefit is about 12 months. Of course, 50% of the patients less, 50% of the patients more. Yes? No, they are on anastrozole. They are on, yeah. So anastrozole is estrogen depleter, so they are on standard treatment. Without the CDK. This is a study that we launched in 2004 is the first time the first patient went on the trial. 2009 is the last patient who went on the trial. And we followed these patients for up until October of this year, actually. And we just published in New England Journal of Medicine two times this publication based on this study. The last one just came out this week. The first one was in 2012, where we showed that there is improvement in overall survival. The current study that just made it to New England Journal of Medicine, it's based on the long-term follow-up of those patients. So we can actually now say what is the 5-year survival benefit in these patients. So 5-year survival benefit has improved from 33% to 42% on the overall population. Generally, that's a very good thing. The longer they're on it, the larger the benefit, yes, because it's kind of tells you that these patients have an endocrine sensitive population, right? Yes. So that's very good, a very good understanding. So, because if you think about it, a tamoxifen treated population didn't get as much benefit, right? They only got a 5-month median benefit. And the hazard ratio is 0.97. So it's only 3% relative benefit, but tamoxifen-treated population can also be subdivided into 2 subsets. Patients who were treated with tamoxifen in distant past and have been away from tamoxifen for 5 years. The tumor has forgotten that it was treated with tamoxifen. Or somebody who is on tamoxifen currently, that patient would probably have a resistant disease to tamoxifen, so likely would also have a resistant disease to fulvestrant, because fulvestrant is a similar agent to tamoxifen. So full addition of fulvestrant would not be as beneficial, right? So there's another study, FACT trial, which is, again, this was largely a negative trial, and the reason it was a negative trial is because it was driven largely by patients who were recently tamoxifen exposed. So if you add fulvestrant to anastrozole, you did not get the bang that you would have gotten if those patients had either never been treated with tamoxifen or they were treated with tamoxifen in distant past. So again, Paloma 1, the overall survival I already talked to you earlier. Paloma 2, similar trial. We are waiting for the results of this. Okay, sorry. Yeah, please go ahead and tell me if you can't hear me. So basically, these are endocrine sensitive patient populations. So now we go to endocrine pre-treated populations. So they are kind of intermediate endocrine sensitive, but they have been treated with endocrine treatment recently. So what are these studies, which is a Paloma 3 study? Again, this was published in New England Journal of Medicine, October of this 2018. And it showed that median survival of patients who were on Paloma 3, if they were on the experimental arm, that means they just got fulvestrant, their median survival was 28 months. But if they were on the experimental arm, their median survival improved to 35 months. So the median improvement was about 7 months. However, it did not reach statistical significance. Okay, yeah. So median. So median is 50%, 50% patients before and 50% patients live on beyond median. So 50% of the patients passed away. So that's, yeah. So this is including everything. This is, so what happens is when patients go on the trial, they are tracked till they live or die. So when they die, it makes, I'll show you a Kaplan-Meier curve, so that will kind of give you an idea. So that's the whole point of doing clinical trial, is you want to track patients to see how they are doing. So I'm not talking about progression-free survival. Progression-free survival is generally about 1/3 of the overall survival. So if they have a 35 months median survival, their progression-free survival was about 11 months in that study. And in the control arm, it was 4.6 months. Remember, these are patients who are not very sensitive to endocrine therapy. So the palbociclib is given to try to reverse the resistance to endocrine therapy. So again, Monarch 2, this is patients who got abemaciclib, and this is in addition to fulvestrant, and we don't have the survival data yet. We do have a Belore 2 trial where there was a medication called everolimus. You have already heard how these medications work in the earlier talk. And what is their median survival is 31 months if they were on the experimental arm, and 26.6 months if they were on the control arm, meaning that they got exemestane. And the hazard ratio was 0.89, so that means an 11% relative improvement in survival. But the p-value is 0.14, so that means it's not statistically significant. It was, in terms of progression-free survival, control of the disease, it was significant, but not for overall survival. So confirmed trial was another trial to try to see if we can optimize the dose of fulvestrant, and that study showed that patients can live longer if you gave higher dose of fulvestrant versus if you gave lower dose of fulvestrant. Bolero 6 was a study to see if patients get chemotherapy versus everolimus and exemestane. Here it seems to suggest that the capecitabine had a better overall survival than if they were on hormone therapy here. And though the authors argued that there were some imbalances between the group, and when they control for imbalances, the survival seems to be the same or slightly worse for patients who were on the exemestane and everolimus arm. For Mona Lisa 3, it is, again, we don't have the data yet for overall survival. But again, these studies show consistently that there's an improvement in progression-free survival by about 40 to 50%. We need to wait for overall survival from these trials. Yes, please. No, they have to, that's a very good question and very insightful question. Yes, we are supposed to, when we say overall survival, it is overall survival irrespective of what they die of. Yes, very important question. That's what, otherwise they would be saying breast cancer specific survival. Yeah, so this study that I took part in, that I had a chance of running this trial, I can tell you that when patients progress in this trial, we actually had a form that the physicians had to fill out. What next agent have you started this patient on? So you know what anastrozole does. It lowers the estrogen, right? So tumors love estrogen, and anastrozole lowers the estrogen, so it doesn't let the tumor feed on estrogen. So we hypothesized that addition of fulvestrant, which blocks the tumor's ability to use estrogen, would improve outcome, because these have complementary mechanism of action. And so we initially, in 2012, we reported that there was an improvement in improvement in progression-free survival and improvement in overall survival. And now we have more than 5 years of additional follow-up on those patients that we followed for so many years. So who were these patients who went on the trial? These were patients who were postmenopausal, whose performance status had to be 0 to 2. That means they had to be out of bed more than 50% of the time to have at least a performance status of 2, right? So they couldn't be in bed more than 50% of the time. That means the tumor weakened them so much that they were in bed, and generally they would not have qualified to go on the trial. So they had to be hormone receptor positive, either by ER or PR. They could not have prior chemotherapy for metastatic disease, no hormone therapy for metastatic disease, or no immune therapy for metastatic disease. They had to have finished their treatment 12 months prior. So they had to be treatment-free for at least 12 months, except in case of tamoxifen. And so prior tamoxifen was allowed, and patients were stratified according to whether they had prior tamoxifen or not. So again, randomization 1:1, that means 350 patients roughly on one arm, 350 patients on another arm, the experimental arm. And importantly, patients who were on the anastrozole arm, the physicians were encouraged to have these patients go on to fulvestrant upon progression if they were on an anastrozole arm. Patients on the combination arm already were on the fulvestrant and anastrozole. So those patients could go on to physician choice treatment, but patients who were on anastrozole alone, they had to go, if they were not in a visceral crisis, meaning that they did not immediately need chemotherapy, that these patients were encouraged to go on to fulvestrant. So the study had a 90% power, that is the strength of the study. That's why we call it power, right? To see an increase in median progression-free survival from 10 months to 13 months. That means amount of the time that the tumor stays under control. And it had a 90% power to detect an increase in median overall survival from 3 years with anastrozole alone to 4 years with combination. And again, it was a statistic, the study design was powered to be statistically significant. So 707 patients went on the trial, and 12 patients were ineligible because they did not meet eligibility criteria. And 1 patient withdrew consent, so we can't report on those patients who withdraw consent. Median age of patient was 65 years, 40% had prior adjuvant tamoxifen, and 33% had prior chemotherapy. So patients on anastrozole arm were encouraged to cross over to fulvestrant. And this is basically telling you that this is 19% improvement in survival, progression-free survival. This is progression-free survival. This is patients who had previous endocrine therapy, patients who did not have prior endocrine therapy, and the benefit in progression-free survival was 0.93 here and 0.73 here. That means 7% benefit and 27% benefit in terms of progression-free survival. And here you have the overall survival. And that's really what you care about, because that's what my patients tell me, will I live long enough to see my granddaughter graduate or my granddaughter get married? So this is 18% improvement in overall survival with a median overall survival of 42 months versus 48 months. For previous endocrine therapy, 43 months versus 48 months. For patients with no previous endocrine therapy was 40 months versus 52 months. Again, the relative benefit is 3% and 27%. So these are the curves that tell you that when they drop off here at 50%, that means those patients had died by 2 years, right? or had progressed by 2 years. So this is progression-free survival. And this is overall survival. So this is again progression-free survival, sorry about that, and this is overall survival. So here you see 50%, almost 3.5 years, and this is 4.5 years, or 50 months. And these are patients who had never had prior endocrine therapy. See the separation between the curves? And this is very important. This is what we live for. We want to see this early separation of curves, and we want to see that these curves stay separated. That means the patients in the blue bar are living longer. Patients in the red bar, that is the control arm, are living for a shorter period of time. And this is statistically significant. That's truly what we want to hear. So AI is aromatase inhibitor, which is anastrozole or exemestane or letrozole. So these are estrogen depleted drugs. So these are the drugs that take away patients' estrogen. Did it come with additional toxicity? So when we follow after the first report, with the second report, we did not see any additional grade 4 or 5 toxicity. So these patients were on combination so some of these patients were on combination not 12 years, 10 years, 12 years. So remember the tail end that we see here? Patients on this one, here, these patients are, some patients are here out to 25%, right? 25% of the patients made it to 7 years, 8 years, 9 years, 10 years, we again see a little dip here. But they never cross each other. So you have, these patients are about 15% here at 10 years. These patients about 25 to 20% out to 10 years. So what are the toxicities? Because that's crucial, because patients want to live with a good quality of life. So if you think about it, patients living for 4 or 5 years, they will have some toxicity. Even if we didn't give any treatment, they will have some toxicity, which we call it nocebo, meaning that we feel that we have some side effects to medicine, but just because we have aches and pains, growing pains. So that's why comparison is so important, because we say what happened with patients on anastrozole and what happened with patients with fulvestrant. So this study actually showed that there was not much difference between the two, despite the fact that patients were being tracked on fulvestrant for a longer period of time, because their disease was controlled for a longer period of time. Patients who were on anastrozole alone, we tracked them for side effects till they were on anastrozole alone, but after they switched over to a next treatment, we did not track them for additional side effects. So these patients were living longer, so we collected more side effects, but still, despite that, there was no statistically significant difference between the two arms. So that means that patients were able to tolerate this. Many of my patients go to cruises. One of my patients went 10,000 feet. So it's possible for patients to live a good quality of life, because these are not chemotherapy agents. These are not causing patient side effects like mouth sores. It's not causing diarrhea. It's not causing reduction in white cells, red cells, platelets. So it does not cause increased risk of infection. So these are very important parameters for patients to consider whenever they are switching over to a treatment or choosing a treatment. And this is for CDK4/6. I'm sorry, how many minutes do I have? Like 2 minutes, okay, yeah. All right, so I think this is just a cycle. This is how the tumor cycles, right? This is when tumor is sitting quietly, not doing anything. But once this is released, this E2F factor is released, that is how the tumor cycles from resting to cycling phase. So CDK4/6 inhibitor stop this progression from resting to cycling phase. And these are the 3 drugs that I talked to you about, and these are the various trials that I talked to you about. And this is basically Mona Lisa 3 background, which is again presented by UCLA colleagues. Dr. Dennis Lehman, you know, this is a physician who was probably going to get a Nobel Prize because he was the one who came up with HER2 targeted agents which improve patient survival. And so he ran this trial called Mona Lisa 3 trial. And basically, he used ribociclib to add to standard treatment to see if it improves patient's outcome. And sure enough, it improved patient. This is the randomization between fulvestrant alone versus ribociclib and fulvestrant. And patients were followed till disease progression or development of unacceptable toxicity. Continued treatment was continued. And then these were, again, eligibility criteria, very similar to the criteria that I talked to you about. And again, median progression-free survival, significant, almost 60% improvement in median progression-free survival. So 18 months if they were on placebo and fulvestrant, and it's not reported if they were on ribociclib and fulvestrant because they had not reached the median yet by the time he reported the data. And the side effects, you do have some reduction in white cells, reductions in platelet, and you have to do an EKG monitoring, and you have to check patient's liver function test. So these are mostly the metastatic settings, so I will ask you to ask me any questions. And I think I couldn't have done it without patients contributing and going on the clinical trials. And this is all thanks to you. Kudos to you for having done what you do. Yes, so some of these trials did not allow patients with inflammatory breast cancer, but the S0226, the trial I talked to you about, we did not exclude patients with inflammatory breast cancer. So they were grouped with the same, if they were hormone receptor positive, they were grouped in the same trial. But we did not select out those patients separately, and we did not analyze them separately. We did not ask the physicians, do your patients have inflammatory breast cancer? Is it stage 4? Right. So I think it is always a discussion between patient and physicians, because if you're talking of anastrozole fulvestrant combination, so patients who qualified to go on the study could potentially benefit. But my thought is that this is an intramuscular shot, so we should really pull out the patient population who really benefited, truly benefited, who drove the positivity of the trial. So who were those patient population? Endocrine naive patient population, or patients who were off the endocrine therapy at least 12 months. So that means basically then we can assume that they have an endocrine sensitive population, and those are the patients who would benefit most by addition of the fulvestrant shot. Because it's an intramuscular shot, and patients have to know that they have to get these 2 shots a month. They come once a month to get these 2 shots. And for majority of the patients, when I ask them, they say, you know, if I can live 8 months longer, 12 months longer, 16 months longer, depending on my endocrine sensitivity, I want to do it. And I had few patients who said, you know, it's not worth it for me. You know, I would rather not, because surely patients who are on the skinny side, they have difficult time with the intramuscular shot, and you know, she said, you know, I don't want to do this. So every patient is different, so it's a dialogue between patient and physicians, what is important to them and what's not important to them. So very good question. So that was one of the questions that when we ran our trial, that was one of the questions. And we asked physicians to make sure that they keep the biopsy, the primary biopsy, the primary tumor biopsy, and if they relapse, that we wanted the biopsy of the relapse, not only so that we can look at these markers again, but also to make sure that this is truly cancer recurrence, right? Because you don't want to treat somebody with just something that PET scan shows up and say, well, you have metastatic disease. No, you want to be able to make a biopsy again. And so we had them do both tissues, but we allowed them to say, okay, these patients can go on the trial if they had hormone receptor positivity at any time, either at the primary tumor or either at the time of recurrence. So unfortunately, we haven't analyzed the data yet to see if we have enough samples, because you have to analyze the samples at a central site to see if those patients have retained ER. But what happens is in the metastatic site, sometimes you don't get enough tissue, and sometimes it's when it's in the bone, it's very difficult to preserve the ER. So sometimes even if we say that this is ER negative, if everything else suggests that patient probably has ER positive disease on clinical parameters, then we might say, let's try a hormone blocker to see if it works again. So, but keeping in mind all the time that we may need to switch to chemotherapy very soon in these patients. But very good question.
On behalf of Susan Jean Komen, let's all thank Dr. Mehta for her great talk.